Hello dear friends, how are you doing today? I hope you are doing well. Today we are going to talk about psoriasis. Definition: psoriasis is an inflammatory rash with increased epidermal proliferation, acanthosis, resulting in an accumulation of stratum corneum or scale. The etiology is unknown but appears to be multifactorial, resulting in inflammation and epidermal proliferation. The clinical appearance is that of sharply demarcated red papules, patches, and plaques surmounted by silvery scales. In this photo, we can see the patches, plaques, and papules of psoriasis with whitish or silvery scale. Here we can see also well demarcated pink-red plaques with white or silvery scales. Incidence: some 2 to 5% of patients of European descent and 0.1% to 0.3% of the Asian populations are affected by psoriasis. Onset may occur at any age but is most common in adults with an average age of 35 years. History: the disease usually starts gradually, although occasionally it is explosive in onset or exacerbation. The sudden appearance of multiple small guttate lesions of psoriasis in a generalized distribution is often preceded by a streptococcal throat infection. Here we can see the presentation of multiple spots or guttates of psoriasis, which has a distributed pattern in the surface of their body. Here we can see also the guttate lesions of psoriasis, which is disseminated on the surface of the body. In patients with severe sudden onset or rapidly worsening large plaque psoriasis, a predisposing human immunodeficiency virus or HIV infection should be considered. 1% of patients with acquired immune deficiency syndrome or AIDS develop severe psoriasis, and sometimes the psoriasis is the presenting manifestation of AIDS. Other aggravating factors that have been implicated in psoriasis include trauma to the skin that precipitates a psoriatic lesion, which is called Koebner phenomenon, and emotional stress, which, although difficult to document scientifically, is believed by many patients to be a contributing factor. Here we can see the lesions of psoriasis appearing in the site of a tattoo, which is called Koebner phenomenon. A few drugs have been found to aggravate psoriasis. Lithium is the best proven culprit, but beta blockers and non-steroidal anti-inflammatory drugs have also been implicated. Itching: psoriasis is derived from the Greek word for itching, ranged from mild to severe. A family history of psoriasis can be elicited by approximately 1/3 of patients. Think of infection with sudden onset or worsening of psoriasis. Physical examination: the lesions are sharply demarcated and, depending on skin tone, red, pink, or dark brown papules, patches, and plaques are surmounted by scale, which is characteristically silvery. In interregnous areas, maceration prevents scales from accumulating, but the lesions remain red or dark brown and sharply defined. Here we can see sharply defined lesions of psoriasis in flexural areas. The erythema and redness is present, but the scale is not common due to the maceration of flexural areas. This type of psoriasis is called flexural psoriasis. Psoriasis is classically distributed on the elbows, knees, scalp, intergluteal cleft, and nails. The intergluteal cleft is also a common site and is frequently overlooked. Although these are typical sites, psoriatic lesions can occur anywhere and may cover the entire skin surface. Here we can see the widespread red plaques of psoriasis. Nail involvement is present in as many as 50 of patients with psoriasis. The nails may be pitted with small ice pick-like depressions in the nail plate. Onycholysis is a separation of nail plate from nail bed can also occur. This condition is caused by a plaque or psoriasis in the distal nail bed with an accumulation of scale which lift the plate from the nail bed. The nail may be thick, irregular, and discolored or yellowish color. Here we can see the onycholysis and pitting of the nails due to the psoriasis. Here we can see also the pitting and discoloration, pitting, and onycholysis of the nails. This photo is showing the pitting and onycholysis of the nail. We can see the accumulation of keratin between the nail plate and nail bed, which leads to the separation of nail plate from the nail bed, which is called onycholysis. Pink scaling fissure patches on the hands often associated with nail involvement is present in psoriasis. Here we can see the nail and finger involvement in patients with psoriasis. Pustular psoriasis is an uncommon variant. In this form of the disease, superficial pustules occur in one of three presentations. Pustules starting more topical plaques, pustules confined to the palms and soles, and a rare generalized eruption in which the pustules erupt abruptly on large areas of red skin and are accompanied by fever and leukocytosis, and this type of psoriasis is very important. Here we can see the pustules of psoriasis on the surface of the body. Here we can see pustular psoriasis with diffuse and confluent erythroderma studied with pustules, and this type of psoriasis, as we said, is very important, and the patient maybe need their hospitalization. Deficiency of the interleukin-1 receptor antagonist and of the interleukin-36 receptor antagonist causes severe neonatal onset and variable age onset pustular psoriasis with systemic inflammation, respectively. Differential diagnosis. The diagnosis is usually not difficult, especially when the lesions have the characteristic cellular scale and involve topical locations. It may be more difficult when the scale is not present, as in extremely early lesions or in intertriginous eras. Intertriginous lesions may be confused with tinea cruris, candidiasis, and intertrigo. Psoriasis of the scalp is most often confused with seborrheic dermatitis, in which the scaling is usually finer, yellower, and more diffuse with indistinct borders. Guttate psoriasis on the trunk is sometimes confused with psoriasis rosea or tinea corporis. Chronic dermatitis and T-cell cutaneous lymphoma can mimic psoriasis occasionally. Nail involvement may be clinically indistinguishable from a fungal infection. A positive potassium hydroxide preparation, a periodic acid shift stain, or a nail clipping or fungal culture enables diagnosis of the latter. Tinea cruris, candidiasis, intertrigo, seborrheic dermatitis, psoriasis rosea, tinea corporis, chronic dermatitis, cutaneous T-cell lymphoma, and onychomycosis all are differential diagnosis of psoriasis. Laboratory and biopsy. A biopsy is usually not necessary. In fact, the clinical picture is often more characteristic than the histologic findings. If a biopsy is performed, the pathologic examination shows hyperkeratosis, parokeratosis, decreased granular layer with an acanthosic epidermis and an inflammatory infiltrate in the dermis that includes neutrophils, and some of which may migrate into and through the epidermis, forming small collections within the stratum corneum, which is called Monroe abscesses. Here we can see epidermis. In epidermis, we can see hyperkeratosis, acanthosis with elongated red pegs and infiltration by neutrophils, forming microabscesses in the stratum corneum is also present. In dermis, we can see capillary proliferation with perivascular inflammation. Therapy. The goal of therapy is to decrease epidermal proliferation and the underlying dermal inflammation. 5 types of topical agents are used: steroids, tar and anthralin preparations, calcipotriene, which is a vitamin D derivative, tazarotene, which is a vitamin A derivative, and UV light. Topical steroids are both antimitotic and anti-inflammatory. Over-the-counter hydrocortisone preparations are usually ineffective, requiring stronger prescription steroids. These agents are expensive but useful for patients with limited areas of involvement. A good response is usually noted within several weeks, but tachyphylaxis or loss of effect with continued use of a drug may develop. Therefore, for long-term use of topical steroids, we instruct patients to use an intermittent regimen. Example, use the agent for only 2 or every 3 weeks, or skip days when doing well. This practice may also reduce the potential for developing steroid atrophy of their skin. Psoriasis also responds to systemic steroids, but this should be avoided because of their well-known long-term side effects and because psoriasis may rebound badly after the drug is discontinued. Topical tars and anthralin are older, less commonly used medications that are hydrocarbons with antimitotic activity. Tars can also be anti-inflammatory. These products can stain skin temporarily and fabrics permanently and are slow to produce a response, although the response that are achieved tend to last longer and tachyphylaxis are less likely to develop than with topical steroids. Anthralin is commercially available in a cream preparation ranging in concentration from 0.1% to 1%. Skin irritation and staining are the main disadvantage of anthralin therapy. Calcipotriene ointment, cream, and lotion are vitamin D derivatives with antimitotic activity. It is applied twice daily and requires several months of use for full effect. It is expensive and may cause irritation but is otherwise safe for long-term use in limited plaque disease. Here we can see the plaque of psoriasis, which is treated after 6 weeks of calcipotriol, after 6 weeks with calcipotriol therapy. As we can see, vitamin D derivatives reduce the scale and thickness of plaques, but not the erythema. Tazarotene 0.05% and 0.1% is a retinoid or vitamin A derivative. In general, retinoids promote differentiation and inhibit proliferation, which is desirable effects for an antipsoriatic drug. Tazarotene is rated as category X for pregnancy, so it should not be used in women with childbearing potential. UV light therapy can be used alone or in combination with other therapies. The least expensive source of UV light is the sun. However, this is often impractical. PUVA has mostly been replaced by narrow-band UVB. Narrow-band UVB that does not require taking sorolin and appears to be safer, less carcinogenesis, is now the preferred UV light therapy. Here we can see the device for producing UV light. We have different type of devices for producing different types of UV light. Methotrexate, a folate antagonist, inhibits cellular proliferation and is effective in many patients with psoriasis. It is administered on a weekly schedule. Complete blood cell counts and liver and renal function need to be monitored at frequent intervals. Some side effects can be minimized with the addition of folic acid taken every day of the week except the day the methotrexate is given. Acetretin, with the commercial name of Soriatan, is a retinoid with profound effects on keratinization. It is administered orally on a daily basis and is particularly effective for pustular psoriasis. Acetretin is a teratogen and is not safe for use in women with childbearing potential. Systemic cyclosporine with the commercial name of Neurol is also approved for treating psoriasis and is very effective in this role. It is, however, potentially nephrotoxic and requires careful monitoring. Biologic agents that suppress the inflammatory response by inhibiting tumor necrosis factor or TNF and interleukins like interleukin 12, 23, interleukin 36, and interleukin 17 are quite effective in treating psoriasis. These agents include etanercept, adalimumab, infliximab, ustekinumab, guselkumab, risankizumab, and so on. Apremilast and roflumilast are oral agents that block the enzyme phosphodiesterase 4 or are phosphodiesterase 4 inhibitors and are effective for mild to moderate psoriasis. Apremilast or biologics are the preferred alternative treatment when topical steroids and or UV light fail to control psoriasis. Janus kinase inhibitors are the newest therapeutic agents for the treatment of moderate to severe psoriasis. In conclusion, therapy for psoriasis: initial steroids, mild potency to strong potency, example triamcinolone 0.1% or clobetasol 0.05% BID, TARS and anthraline, calcipotriene ointment, cream or solution BID, tazarotene gel 0.05% or 0.1% daily, UV light like sunlight and tanning salons. Alternative like UV light, narrowband UVB, and PUA, methotrexate, acitretin, cyclosporine, biologics like TNF, interleukin 17, interleukin 12 and 23, and interleukin 36 inhibitors. Phosphodiesterase 4 inhibitors and JAK inhibitors are the therapy for psoriasis. Course and complications. Uncommonly, psoriasis affects the total body surface, resulting in erythroderma with its associated complications, which include loss of heat, fluid, and protein. Hospitalization may be required. Arthritis accompanies psoriasis in approximately 5% of patients, and psoriatic arthritis is often diagnosed years after the skin findings are present. So patients must be asked about joint pain at each visit. Methotrexate and biologics are useful for psoriatic arthritis and are indicated particularly in the rapidly destructive type or arthritis multans. Here we can see the destruction and involvement of the joints with a psoriatic arthritis multans. In this type, usually DIP or PIP joints is involved. Pathogenesis. Many patients with psoriasis are genetically predisposed. Some 35% have a family history of psoriasis. In identical twins, the disease occurs concurrently in 80%. The precipitating factors responsible for unmasking this genetic predisposition include streptococcal infection, stress, smoking, drugs, and physical trauma. Clinical observations, laboratory studies, and targeted therapies support the immunologic basis of psoriasis. Many experimental data now suggest that psoriasis may be a T-cell mediated autoimmune disease driven by T helper cell and 17 cytokines. The therapeutic effectiveness of cyclosporine and biologic agents, which are T-cell targeted drugs, supports this theory. Investigators have noted that neutrophils extravasated from the superficial dermal capillaries invade the epidermis. Raised levels of leukotrienes, one of the products of retinoic acid metabolism, have been found in psoriatic skin. Whereas mediators of inflammation like TNF-alpha, interleukin 12, and interleukin 23, they may attract neutrophils and may provoke epidermal proliferation. This leads to an increased number of dividing cells, culminating in an orgy of epidermal proliferation. Cellular turnover is increased sevenfold, and the transit time from the basal layer to the top of the stratum corneum is decreased from the normal 28 days to 3 or 4 days. This process is too fast for the cells to be shed, so they accumulate, resulting in their characteristic scale. As we can see here, the cell differentiation and proliferation usually happens in a basal cell layer, and it takes 28 days for the cells to migrate from basal cell layer to the top of stratum corneum for shedding. Usually it takes 2 weeks for the cells to migrate from basal cell layer to the top of the stratum granulosum, and a further 2 weeks for migrating from stratum granulosum to the top of the stratum corneum for shedding. But this duration in psoriasis is decreased from 28 days or 4 weeks to 4 days, and the cells does not have enough time for shedding, which leads to the accumulation of the cells in their stratum corneum. Okay, this was a short explanation about psoriasis presentation and management. Thank you for your attention.